Good day, everyone. In the next 15 minutes, I'll be presenting about integrating oral and mental health with HIV and sexual and reproductive health care for adolescents. And I'll be focusing on Nigeria, which is where my experience comes from. I'll be using this outline. First, I'll be highlighting the importance of integrating oral health care. Then I'll be sharing our experience with respect to integrating mental, sexual, and reproductive health for adolescents. And my experience comes from Nigeria once again. I'll be talking about the nexus of HIV within this interconnectedness. And then I'll highlight our proposition for facility-based management of oral, mental, and sexual reproductive health in adolescents. And then I'll conclude. And like we do all know, World Health Organization is promoting integrated healthcare delivery because this is the way to go. It has multiple advantages, one of which is the fact that it's cost-effective. Because through integrated oral healthcare approaches, you'll be using a common risk factor approach where you identify a risk factor, invest in eliminating this risk factor, and you should be eliminating multiple diseases. In addition, it improves access of service recipients to services and improves adherence to treatment. Of concern here is adolescents' adherence to HIV treatment. Integrated healthcare service delivery also increases patient satisfaction. But more importantly, it also improves their self-care because they also have increased and better access to health literacy. And for healthcare workers, it improves their job satisfaction. For clients, it improves the oral healthcare approach and outcomes. And oftentimes, integrated oral healthcare is promoted and delivered through the primary healthcare services. But we do know that it's possible to do it at secondary healthcare as well as tertiary healthcare level, albeit it may be difficult. We do know that there's been investment and there are multiple platforms through which maternal and childcare integration happens. And what we see now is that oral healthcare is being latched on to these existing platforms. And this is very important because it's very well known that maternal oral healthcare influences children's oral healthcare. And integration can happen for children at this level, infants, toddlers, and preschoolers. But more importantly also is that the delivery of oral health care on this platform can happen by any practitioner, general practitioners, pediatricians, nurses, and therapists. It doesn't have to be oral health care practitioners. In addition, we do know and have reported about successes when oral health promotion and education is integrated into antenatal care of pregnant women. The outcome is so that the children born have better outcomes in terms of their oral health. And like I did note, there are multiple models to explain this. For school-age children, oral health care can be integrated into school healthcare programs. And usually the school healthcare programs is focused on reducing sugar consumption with the aim of controlling caries and malnutrition. And promotion can be through integration of oral health education into school nutritional education curriculum, or integrating oral healthcare programs into school nutrition programs. One of the things we've seen is that countries where the sugar taxation is being promoted, the school programs also promote ways of reducing sugar consumption to adhere to the policies in the country. In addition, programs like the WASH, which is Water, Sanitation and Hygiene Programs promoted by WHO as well as UNICEF, improves access to oral hygiene, and Thailand is an excellent example of where this is done. What happens is that children do their breaks. As soon as they come back for break, the first ask to wash their hands, which is the hygiene practice. They take their food, improves nutrition, and then they go back to wash, brush their teeth with fluoridated toothpaste, and that's the oral health element. And this has significantly reduced the burden of oral health diseases among school children in this country. So WASH is a platform that is also feasible, but there's very little known about how WASH is promoting oral health care. I think my team is one of those that have shown that for adolescents, WASH can push and address caries program. It's associated with caries amongst adolescents. When we look at cancer prevention also, cancer has common risk factors with oral cancers. Other cancers have common risk factors with oral cancer, tobacco and alcohol particularly. And what we see being done is that in oral health care clinics, competencies are being built amongst dentists to improve their ability to provide tobacco cessation counseling. And the focus is also adolescents, because tobacco and alcohol consumption that starts in adolescence can affect their health along their life course. So oral health practitioners also can have the competency built to deliver other forms of programs, not just focus on oral health. When we look at integrated oral health care for adolescents, here's the problem. We don't find those models existing like we have for other age groups, adolescent, preschoolers, schoolers, elderlies, for cancer, but not for adolescents. And we do understand that this has its own peculiarities. You know, they can be found in one place. For example, we find adolescents in primary school, tertiary institutions, secondary health institutions. Adolescents don't readily come into health facilities. You have school-based adolescents, you have out of school-based adolescents, and in Nigeria, as high as 60% of school, 40 to 60% of school children can be actually out of school, depending on the region where you are. So there are peculiarities about them, but it's not impossible. We must address this. We must find a way of integrating services for them and latching on issues that are of importance to them. For adolescents, issues of importance is mental health and sexual and reproductive health. These are stigmatized services and therefore keeps adolescents out of facilities because it's stigmatized and then not getting support from healthcare providers. And so our proposition is to use a non-stigmatized platform to deliver stigmatized services. Mental, sexual and reproductive health are stigmatized, oral health is not. Okay, and in addition, you find that adolescents can readily access oral health clinics who have aesthetic issues. Also, oral health clinics are not fastidious about parental consent, which is a problem with sexual and reproductive health care access for adolescents as well as mental health care access. In Nigeria, for example, the oral mental sexual and reproductive health integration approach has been identified as a means of reaching out to adolescents, and it's in our draft National Oral Health Policy, the 2022 National Oral Health Policy, but we don't have evidence that to support the translation of this policy into practice. And therefore, my team were looking at this, and one of the things we did in 2016 is develop this conceptual framework. I'll refer you to that article published in the International Journal of Adolescent Medicine and Health, where we looked at two oral diseases, dental caries and periodontal disease, which are the most prevalent. We looked at mental health issues, anxiety, depression, and stress. We looked at predisposing factors to this mental health disorders, psychoactive substance use. A common risk factor for all the diseases is tobacco. And then we look at sexual and reproductive health problems, sexual violence. We've shown that rape is very high in Nigeria, and rape increases the risk for HIV. Sexual transmitted infections also. High prevalence of sexually transmitted infection is not treated, and it's a predisposing factor for HIV. And of course, within all this, we don't leave out the issue of peer pressure, which is important to adolescents. We don't leave out diets, and of course, the issue of personal hygiene. We then in 2021 went out to do a number of studies, and this is what our studies found. When you look at the red arrows, we didn't find a link, but when you look at the green arrows, we found a link. And some of the studies showed very clearly some links between the three. The use of psychoactive substances, for example, increased the risk for caries, and the same substance use was not associated with gingivitis. However, dental anxiety, we found was associated with moderate to severe gingivitis. We do know dental anxiety is a form of mental health issues. When we, however, studied mental health as a concept, we did not find an association between it and caries and gingivitis. In another study, we focused on psychological distress, and we found that psychological distress as a mental health disorder was associated with increased consumption of sugar, or rather, apologies, lower consumption of sugar, but lower number of multiple sex partnering also. However, psychological distress increased engagement in risky behaviors. When we assess risky behaviors, looking at sexual reproductive health behaviors alongside oral health risky behaviors. Depression on its own was associated with higher sexual risk behaviors, showing that there's a complexity. It's not as straightforward as A is equal to B. We looked at sexual abuse and found that sexual abuse, adolescents that had a history of sexual abuse, were at a higher risk of having high dental anxiety. And those that had high dental anxiety had an increased odds of alcohol intake. We do know alcohol intake also may be associated with high sexual risk behavior. We looked at suicidal ideation and found that adolescents that had suicidal ideations had reduced frequency of toothbrushing and increased risk for poor oral health. Hygiene. We also found that they also had significant increase in risk for sugar consumption. However, when we looked at the gender with respect to sugar consumption, we found that actually it's females that actually had an increased risk for sugar consumption when they had suicidal ideation, and not males. Males actually had a decreased risk for sugar consumption. We also looked at practices and found that anal, vaginal, and sexual oral sex were associated with a higher risk for moderate to severe gingivitis, though this finding was not significant, and that those that had one or more sexual partners had a higher risk for caries, though this was not significant also. We also had 4 other studies that looked at the connection between HIV as well as, sexual and reproductive health. And we found that adolescents living with HIV were more likely to report a history of sexual abuse, engagement in risky sexual behaviors, and poor knowledge of contraception. In terms of risky behaviors, we found that they were more likely to engage in transactional sex, more likely to engage in unprotected anal sex, and more likely to engage in sex with persons 10 years older, which makes it difficult to negotiate condom use. And therefore, we went on to propose this model for integrated oral healthcare service delivery for adolescents using a continuum of care. And therefore, when adolescents come into clinics, there must be systems and structures in place that can ensure they have access to care, one of which is ensuring quality and safety. Policies must support this. The clinics must provide private and confidential services and risk mitigation approaches. The care team must be trained on youth-friendly and youth competency, and they must also promote peer support. And once again, it's not just oral healthcare professionals that should be trained, but a complementary of multidisciplinary clinicians can provide the services. Finance is critical. Adolescents must have financial independence to be able to provide the services. And financial independence can be through access to health insurance that promotes independent access of adolescents to the services. When care is provided, they should have same-day appointment and not referrals, and ensure after clinic access services and online access to their care managers. And care and case management, once again, can happen at primary oral healthcare. The integrated approach can happen at primary oral healthcare level. We must also promote this access at secondary and tertiary healthcare level. And the services, once again, should be promoted through gender and cultural sensitivity, and it must focus on patient-centered care. In addition, we also did note that those dedicated hours may not be easy to approach. While we promote specific days in primary healthcare centers, we also realize in secondary and tertiary healthcare, those that 10 to 16 might be in the child clinic, and those that 17 to 19 might be in the adult clinic. And therefore, those in the adult clinic, we do ask or propose that they should have specialized access, maybe in oral medicine clinic, a special clinic where adolescents access is dedicated to, not that you make them go around all clinics. But once again, it's about building the competence of staff to deliver this integrated care. In conclusion, I would like to note that for us in Nigeria, this is a big deal because we do have a large population of adolescents. It's estimated about 30% of the population are adolescents. But in addition, we'd have a high burden of untreated oral diseases, as high as 64% of children with oral caries and after caries not treated. So it's a big issue. And adolescents also have a high risk for mental, sexual, and reproductive health problems. My team conducted a study in a semi-rural area where we found that 60% of adolescents had at least one adverse childhood experience. And we do know adverse childhood experiences increases the risk for mental, sexual, and reproductive health problems. So without designing proactively, or rather, even if it's late already in the game, but we must respond, otherwise we have a larger crisis to deal with down the line. And this might involve us to create new platforms for actions, The old ones might not be delivering what we want. We must create new platforms. And integrating oral health care for adolescents using an oral health care platform is one of the ways we're promoting to go. These are my references. I'd like to acknowledge my team members who have worked on this, and also to say thank you for listening and the opportunity to be able to discuss this. Thank you.